Hey there, folks. Good evening. This is the place you're supposed to be. I'm Dr. Randy Fink, and it's straight up top of the hour on Tuesday evening. It's time for Fertility with Fink. Live from Pensacola, Florida, where I am a fertility gynecologist at New Life Fertility, part of the wonderful First Fertility Network. And it is a pleasure to be here with you as I am every Tuesday evening at this time. We have offices let's see, we're here in Pensacola. We've got offices in Mobile, Alabama. We've got Panama City, Florida. And indeed, we see folks from all over this great nation of ours, and we are here for you, able to consult and talk about whatever you want to talk about. And here we are, like we are every Tuesday, to talk about getting pregnant, about making that family, about having those kids, about pregnancy and fertility and all things women's health. I'm happy to see all of you this evening. We've got some different feeds here. We've got an Instagram feed for New Life Fertility on this side. Here's my Instagram feed, and that's Randy Fink MD. Thank you for following me. We've got let's see, we've got Facebook right here for MCRM, which is the Missouri Center for Reproductive Medicine, where I am also on the part-time staff with my wonderful colleagues there. That's in St. Louis, with also an office in Tulsa, and I go to both there. Happy to see you there as well. We've got LinkedIn, and we've got YouTube over here. Excuse me, we are all thanks to all people here tonight, and feel free to throw your questions. And hey to Sheila and to Shayla, nice to see you this evening. Marlena, Midgie, the Bama Gal, my mom, thank you for being here. Easy, looks like Easy E113, you are the first one to join here tonight. So thank you so much for stepping in. You get the gold star. Hey, Red Bear, nice to see you. And Tiffany, the sun-kissed cutie, glad to have you here. Rosa, as always, very pleased that you are with us when you should be spending some time taking care of babies, right? Isn't that what your life is all about right now? I think probably so. Rosa had a baby not too long ago and is enjoying motherhood. Hi to Mrs. Jones in Gulf Shores. Thank you for being here this evening, and I hope you are feeling the love tonight, because you've got an exciting week ahead of you. By the way, if you are part of our practice here in Pensacola, you know that we're doing retrievals this week. If you're at MCRM, retrievals I think probably ended today after this weekend. So I was actually supposed to go to St. Louis to do retrievals last weekend, but fortunately, American Airlines stepped into my plans before I had a chance to execute on them too much, and all my flights got canceled long before I ever even had to leave home. So I did not get any report to see how bad things got up there in St. Louis, but I know it was cold. I know it was very, very cold, so it was kind of nice just to stay home here. A little chilly out here too in up in northern Florida along the panhandle. It's 45 degrees outside here tonight. That's pretty chilly for us. I think it's going to drop down. We're looking to get some ice tonight. Oh, let's see who else we have here. Hey to Angela, glad you're here this evening. Carla and Gwenny. Hello, Gwen. Nice to see you. Evie is with us, as is my dear friend Aaron. Thank you for being here, even if it's only for a few minutes. Hey, folks, by the way, at 5:30 or at half past the hour, we do the 5:30 Fuzzies with Fink. And what is that? That is where we all kind of get together and try to break the internet with some kindness and send out good vibes to all those folks who are needing those vibes tonight, whether it is for fertility, whether it is for health, whether it is for work, for relationship, for school, no matter what. This is the opportunity for us all to stand together as a community and send out those good vibes to each other. So what else is going on in your world here this evening? I had a question about... There was a question about the type of procedures that are done for men in order to be able to get sperm from the testicle. And that sounds really barbaric, it does. But let's say that a man has had a vasectomy. If he's had a vasectomy, the plumbing has been fixed such that he's still making a ton of sperm. They just have no place else to go. So ultimately, they are reabsorbed into the man's system. Well, in the event that that man and his partner decide that they would like to get pregnant, you have a couple of options. One is you can go to the trial and expense and frankly, the pain of trying to get a vasectomy reversed. That basically requires taking that tubing and trying to reattach it all together and to keep that from scarring again, such that it will allow sperm to be transported from its point of manufacture in the testicle to its location kind of in the glandular structures of the male reproductive system and ultimately out the door in order to be able to do its thing, which is to fertilize an egg. Well, so let's say that that's not a very good option. Another option is that we can do what's called a TESA. TESA. And basically what that is, the SA part is a sperm aspiration. There's another with a TESE, which is a sperm extraction. And basically what we do is that we numb the testicle. This is done. We do them here in our office. My partner, Dr. Rips, does this. Put a little numbing cream on the testicle so that nobody feels anything. Then with a needle, we do some additional numbing of the structures in the testicle so that then the man literally feels nothing. And for probably about the next 5 minutes, they both just kind of sit together and tell jokes. They hang out. It's done in our procedure room here, but really not a big deal at all. A needle is placed within the structures in the scrotum, and the sperm is aspirated through a needle into a syringe and goes to the laboratory where our embryologist confirms that indeed there is sperm. Most of the time that sperm can be divided up into a number of specimens so that then it can be used later on. And that is the process of aspirating sperm. Now, we know that sometimes, all right, so it's pretty clear if the guy's had a vasectomy, right, then we know, all right, there shouldn't be any sperm that's really coming out. So there's one indication, but why else might you need to do a procedure like that? And the answer is, well, when we look at a semen analysis, right? Look at that semen analysis. One of the things that we look at is known as morphology. The morphology means what does that sperm look like under the microscope? The sperm they have a head, they have a neck, they have a tail, and it's somebody's job to sit and look at that sperm and make those assessments from one slide to the next. Well, we know that when there is an issue with the way the sperm look, and that's something that's called teratospermia, then sometimes there can also be issues with the way the DNA or the genetic material in that sperm will function. And there can just be issues altogether with the sperm itself. Now, teratospermia is not in and of itself a cause of infertility. However, it is associated with couples who have a difficult time getting pregnant. So, one of the things that we think is that teratospermia actually happens not so much in the way the sperm are made, but rather it's something that happens to them in the transport mechanism for them to come out. So sperm are transported through the vas deferens. They go to the seminal vesicles. They go through the prostate. They're initially stored in the epididymis in the testicle. So there's a lot of places and a lot of tubing, a lot of areas where sperm can start to get messed up. And the thinking is that if that somewhere in that process, sperm is getting affected or can be getting affected in a negative way. So in a case of persistent teratospermia, we might start to look at things like the DNA fragmentation in that sperm, and that we may be able to get better sperm by taking it directly from the testicle rather than having the male produce that specimen in a normal way. So that's a real thing. And a patient asked a question, why would they suggest that my husband have to do an aspiration of sperm instead of just ejaculating that sperm? So without knowing the specifics, that may be one reason. And with the vasectomy, that's, kind of potentially another. So there you go. Let's see who else we have here. And a very happy Tuesday evening to MCRM in St. Louis. Thank you for joining on the show and for allowing me to broadcast on your Facebook page to all of our friends in St. Louis and in the Tulsa area. What a wonderful place. What a wonderful practice that is. Really a full service place, and I can't speak highly enough about all my colleagues there. Let's see. La Mujer is here. Hi, Amal. Nice to see you this evening. Angela asks, can you please explain the name of the other Zymote option? You mentioned it last time, and it's called beads. Yes. So let's talk about that a little bit. So what even is Zymote? Zymote, some people call it Zymot. I think the correct pronunciation is actually Zymote. I always call it Zymot, so don't get me into trouble. But this is a sperm preparation device. So when you're doing IVF, what happens is that an embryologist sits down at a microscope and selects an individual sperm, one sperm for each egg. So we rev up the ovaries, get you to produce as many eggs as we can in order to retrieve those eggs from the ovaries with the goal of placing one sperm inside each egg. And so that's what the embryologist does at the microscope. The whole goal here, though, with something like Zymot is where we can allow that embryologist to have a better pool of sperm from which to choose. So Zymote, or Zymot. I'm just going to call it Zymot. So sorry if I'm pronouncing it wrong, and I think I probably might. I really do think it's Zymote, but I've just always called it Zymot. So that's what it's going to be, doggone it. Don't make me say it again. If with Zymot, what happens is that, and think of it as like a little obstacle course. It's a little cartridge with an obstacle course in it for sperm. So you put the sperm in one end that runs through the obstacle course, and the better sperm are the first ones to come out the other side. These are the stronger swimmers. These are theoretically the more normal sperm. So this is a methodology of being able to select better sperm from which the embryologist will then select individual sperm. So that's option number one. In most places, Zymot is an add-on. It's something that typically costs a couple of $100 extra to do it. Here at New Life Fertility, we do that as part of everyone's sperm preparation. So, or at least something that's very, very similar. It's that same type of thing, but that's included. There is no extra cost for that here. So, and speaking of which, none other than Dr. Williams, our embryologist, has just joined the program. Dr. Williams, thank you for being here this evening. Okay, so Zymote, he's saying. Okay, you know what? I refuse to go there. I'm not even going to, if I want to call it Zymot, then it's going to be Zymot. You got it? Okay. You know, you can't get good help these days. You just really can't. So there are a couple of other methodologies that can be used in order to try to help select an individual sperm. That's a good one. And at MCRM, for instance, there are up to 3 options you can use. Zymot is one of them. Zymote is one of them. Beads is another. And with the beads, basically, the goal is, we call it, just think of it like this. You're placing sperm onto a media, and the sperm that identify themselves as the ones that stick to that media are thought to be the better sperm. So therefore, you can select sperm that way as well. And so the way I think of it, and to be honest with you, I've never actually seen it done, but these beads, I think of, a bunch of little beads, sort of like, oh, look, wait, I actually have some beads right here. I think of them sort of like these beads. Of course, this one says best dad. So, but they probably don't say that in the embryology lab. They may just say best sperm or something like that. But so I think of these beads, and these beads have a substance on them that's sticky. And so the better sperm end up wanting to stick to the beads. Okay, and so then they can go to the beads and they can select the sperm that are sticking there. So maybe first you run it through Zymot and then you run it through beads. There is another methodology that's called PICSI, PICSI. And PICSI is yet another methodology for being able to select sperm that is most commonly used in cases of previous really fertilization failure. It's not something that is appropriate to use in every scenario. So I don't want people to hear this and say, well, I want that. I hadn't heard of that. I want to do that. And maybe that means, I haven't been able to get pregnant so far, so I want to do PICSI. It really has a specific indication, and the best indication there is for situations where sperm has not been able to fertilize really kind of the eggs at all. So, but most commonly, I would say at MCRM, they will use Zymot and beads. And Angela asked, so what would be better for use with severe DNA fragmentation? And I would say probably both of them. They at MCRM typically use at least two different selection methods for sperm, both beads and Zymot or PICSI and Zymot. So now in your case, Angela, where you know that you have severe DNA fragmentation, which means that the genetic material in that sperm has been sort of unwound, as it were. The first thing I would say is, well, what we do know is that by increasing the frequency of ejaculation, we typically will get better sperm. So, when a guy does a semen analysis, we say that, okay, so the optimum time for refraining from ejaculating is, roughly about 3 days, because when we do that, we're able to maximize the sperm count. However, when you maximize the count, you're not necessarily maximizing that sperm quality. And so what can happen there? And so when we're doing IVF, generally speaking, I recommend our patients here at New Life that they have ejaculated at least the day before they produce the specimen that's going to be used for the IVF, because you tend to get better sperm. So less DNA fragmentation happens when ejaculation is more frequent. But so, I would say, Angela, probably both those methods would make good sense. And that would be the precise indication really for using both Zymot and beads. Now, if where you are, they don't offer beads, all they offer is Zymot, well, then that makes perfect sense to me. And I think it's probably a good thing to do. Zymot is not something that is, it doesn't cost $1,200 to do it. If it was costing, a significant increase in the cost in order to do it, I'd say, well, where's the evidence? Show me how this is really a good thing for everyone, because I don't know that data is there, but it's not an expensive add-on for the places that charge for it. And so I do think it's probably a reasonable thing to do for a couple $100 there. All right, let's see. I think I passed up a question here before. Couple of them here. Can you? I think I just answered that one. Sorry about that. There was a question I saw about, here we go. Easy asked about the FET supplements and why each is important. So yes, let's talk about the vitamins that are part of the evidence-based protocol for you to do an embryo transfer. A quick question, Angela said, does CNY offer beads? I don't think so. CNY does offer Zymot as far as I know, or at least they did when I was there, and I'm pretty sure they still do. But I think that's the only other sperm preparation method that they offer. But I can't say for sure. Okay, so first thing is prenatal vitamin. Okay, that one ought to be a duh. Everybody knows if you're trying to get pregnant, you ought to be on a prenatal vitamin. What's the most important thing about the prenatal vitamin? And the answer to that is the folic acid. So you should be on a vitamin with folic acid for 3 months prior to conceiving, because that decreases the risk of certain types of spinal birth defects known as spina bifida. 3 months of folic acid. If you don't like taking a prenatal vitamin, then just get the folic acid. That's okay too. Now, just a word here, if I may, about prenatal vitamins, because there's a lot of noise out there, and you may have heard me talk about this before. You may have heard me say this before. So if it's repetitive, I apologize. But, there's $120 prenatal vitamins out there. And you might say, oh, that must be so good because it's so expensive. It's so expensive, it must be a good thing for me. And I would say, well, if that vitamin can guarantee you that your child will get a full scholarship to Yale, then scrounge up the $120 and get that vitamin. But that vitamin can't make that claim. It's a vitamin, and most of it ends up in your urine. And so for a multivitamin, there's just no reason in general to pay that much money. There are gummies from Walmart for $8 that are probably really, frankly, do about the same thing. And maybe they even taste better because they're gummies and sometimes they're coated with sugar, and that's just yummy. So don't overspend on a prenatal vitamin. The only thing really that prenatal vitamin needs is 400 micrograms of folic acid. Now, some of them have 800 and some of them have 1200, and all that is well and good, but all you need is 400. So overspending on a prenatal vitamin, not necessary. Let's see, what else? CoQ10. CoQ10 is an antioxidant. And to me, really, it's most important as it pertains to egg retrieval and for egg quality, but it also does have to do with the way you build your lining, your endometrium, and the health of that endometrium and its receptivity for an embryo. So there are two types of CoQ10. One's called ubiquinol. That's the type that your body naturally uses. If you're taking ubiquinol, 200 milligrams twice a day. The other is called ubiquinone. Ubiquinone is the form that your body has to convert it in order to get it to work. And that's really kind of more common in most of the over-the-counter supplements, ubiquinone. You just need a little bit more, and that's fine. You need a minimum of 600 milligrams a day or 300 milligrams in a divided dose, so 300 milligrams twice daily. Okay, so we got prenatal, we've got CoQ10, we've got fish oil or omega-3. Fish oil is a phospholipid. It is a strong anti-inflammatory. Once you do get pregnant, the only two things you really should stay on are, number one, the prenatal vitamin, and number two, the omega-3, the fish oil. Now, fish oil goes by different names, DHA, EPA, and let me call attention to the fact that DHA is not the same thing as DHEA. That's something completely different, but just look for fish oil, omega-3. Word to the wise, and that is if you're going to get fish oil, I always tell people get the one that says odorless or burpless, because it literally comes from a sardine. And they're going to take a sardine and wring it out into a little capsule, and you're going to swallow it, and you're going to burp that back up. And if you burp that back up, it may cause indescribable levels of damage to the environment, not to mention your relationships, because the taste of that burp back is truly, truly vile. So at one point, I like to tell a story. I went to Costco, and I saw, here's 2,000 fish oil capsules for $1.99. I'm like, oh, this is great. Gosh, this is wonderful. I'm going to get that. I got it, and I took exactly one of them, and the rest were returned to the sea by the way of the toilet, because and let me tell you, the toilet really didn't appreciate it either, because they were just absolutely noxious. So odorless, burpless is probably a good thing. Okay, vitamin D. Vitamin D is important for implantation. Optimum vitamin D level, we would like to be between 60 and 80. So anything above a 30 is considered normal, but I really, from a longevity standpoint, from the anti-aging standpoint, between 60 and 80 is really what we're looking for there. Vitamin E is important. It is also an antioxidant and works at the level of the endometrium. And the last thing, and all of those things are actually on the list for egg quality as well. There's only one other thing that's not on that list for egg quality. In fact, I don't want people taking it when they're trying to, planning on doing a retrieval. That's something that's called L-arginine. L-arginine increases a chemical in the body known as nitric oxide, which increases blood flow. And ultimately, that blood flow goes to the uterine lining and helps to beef up and make a juicier, more warm, spongy, happy place for an embryo to implant inside the uterus. L-arginine. L-arginine has been shown to cause chaotic growth of eggs, however. So L-arginine is explicitly not recommended in folks who are doing an egg retrieval. So please don't take it in that regard, but do it for your embryo transfer. The one other supplement I will mention is specifically for people who have a history of endometriosis. And if you have a history of endometriosis, then 1,000 milligrams of vitamin C goes along with that. So there you go. That's your evidence-based protocol for embryo transfer: prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. Add the sixth one, 1,000 milligrams of vitamin C, if you've got a history of endometriosis. All right, thanks for that question. Hey, it's half past the hour, so I want to just take a moment to do what we do every week at this time, and that is to just pause and send our thoughts out to all those folks who need a little extra word of support, who need to just know that they are not alone during these difficult times. And these are difficult times. You watch the news just as well as I do. In fact, our friend who is frequently participates in this broadcast, her name is Angela, and she is a nurse practitioner in Minneapolis. She worked closely with the individual who was an ICU nurse who was recently killed in town there, and they are really all devastated by having to deal with that. Fertility is a hard thing to go through. Relationships are hard things to go through. School is hard. Work is hard. The world out there is not an easy place for us. It is constantly challenging us and constantly making us feel alone. Well, at this point during the broadcast, I like us all to stand together as one community and break the internet with our positive vibes going out to each and every person tonight who needs to know that they are not alone in this struggle, that others struggle with the same thing, that the difficulties we have from day to day is something, these difficulties are things that we share together as a species. And I think pretty much everybody who's on this show tonight would stand behind each and every other person here if they knew that that person needed to hear from them, that they're not alone. So the 5:30 Fuzzies with Fink, here it is. Let's send out those vibes right now. If we could do a group hug, I would do it, but logistically, it's just tough. That, my friends, is the 5:30 Fuzzies with Fink, and thank you for being a part of that. Do something nice for a stranger. Surprise someone just with random acts of kindness, because the world out there is not a nice enough place. And what can we try to do is to try to change that one mind at a time. So Thank you for being a part there. Hi to Sabrina on the Facebook side. I had 3 follicles. One was 15 millimeters and the other 2 were both 12 millimeters yesterday. I go back tomorrow to see if any of them matured, but I'm so anxious. I've been getting negative ovulation tests. So how likely would I ovulate with those follicles? Well, so, I would consider a mature size follicle to be 17 to 18 millimeters. So my guess is, Sabrina, that by tomorrow, at least one of those is likely to be of a mature size. They typically grow 1 to 2 millimeters a day. So the 12s, maybe 14s by that point. So just kind of depending on what sort of treatment you're doing. If you're doing ovulation induction, 2 or 3 follicles is pretty good. Kind of depending on your age. Sometimes we say 3 follicles might be a little much if you're, on the younger side, because we don't want you having triplets, obviously. But yeah, my guess is that if you don't typically ovulate, but you've got these 3 follicles growing, you've done some kind of ovulation induction there. So it sounds like it's going to do its thing for you, and you are absolutely going in the right direction. Quick question here from Kelly. And how long do you recommend taking those vitamins that we talked about before the FET? Well, so again, the prenatal for 3 months prior to conceiving. So you should just really be on that one. The other ones can start at the beginning of your embryo transfer cycle. So you don't have to be on them for extended periods of time, really just for that cycle when you're building that particular lining in order to try to get an embryo inside. So let's see what else we got here. We had some other wonderful questions here, and I just had an embryo transfer today. This comes from Amal. We transferred 2 day 3 embryos. What are my chances of getting pregnant, and should I continue taking L-arginine and myo-inositol? Okay, so the answer to your question, chances of getting pregnant really depend entirely on the age you were when you made those embryos. So a day 3 embryo, there's nothing wrong with a day 3 embryo, but many practices will say, well, we're only going to transfer blastocysts or a day 5 embryo, because if they have grown to that point, to day 5 or to the blastocyst stage, we know that they have a higher probability of being able to get you pregnant. With a day 3 embryo, we just don't know about that embryo. We just don't know if it was going to be healthy enough to continue to grow on its own. So when you put it in, and if it doesn't stick, we can't really say, is that, why was that? Because we don't know if that embryo was going to grow at all. Now, for one strategy is for older moms, let's say women in their 40s, to transfer multiple day 3 embryos in the hopes that one of them will stick. And that ultimately results in fewer unsuccessful embryo transfers. If it's a normal embryo, it doesn't matter whether it's a blast or it's a day 3. Hopefully normal means it sticks. The question is that day 3 going to be normal? Well, it has a lower probability of being normal than a blast, but if it's normal, it's normal. And it's going to stick. So our fingers will be crossed for you there, my friend. Yeah, and I would say, so the myo-inositol is something that is similar to the medication we know of as metformin, and particularly if you have polycystic ovarian syndrome or certain other types of metabolic concerns, being on myo-inositol or metformin can pretty significantly decrease your miscarriage risk. And so I would say, I think it's fine to stay. You can actually stay on myo-inositol throughout the entire pregnancy. The L-arginine, I would say once you get a positive pregnancy test, that's time to stop all of the other stuff except for the prenatal and the fish oil, the omega-3. Rosa asks, can Lovenox cause a subchorionic hematoma? I had a big one with it, and I had no coagulation disorder. Okay, so you're asking about Lovenox, and Lovenox is a blood thinner. And there are some practices that routinely employ blood thinners for patients who have done embryo transfers. And the thinking there is that, that there are some people who have some type of issue in their blood that causes the blood to clot. And these clots can affect the tiny blood vessels that supply the placenta and can prevent you from either getting pregnant or from staying pregnant. So some practices advocate using that medication for everyone. I don't advocate that. There are certain scenarios, excuse me, there are certain scenarios when I do think being on a blood thinner makes sense. Sometimes we'll just even use a baby aspirin, particularly in folks who have had recurrent pregnancy losses. We can do a series of tests to see if you have those issues in your blood that require you to be on Lovenox. And so it certainly begs the question, a subchorionic hematoma. What's a hematoma? A hematoma is a bruise. Subchorionic basically means underneath the placenta. So what can happen in a lot of people is that as the uterus grows and the placenta kind of moves along with it, it can have a little shearing force on the inside that ultimately can result in creating a little bruise in there. And I would have to say, certainly if you're on a blood thinner, that may increase the risk for that happening. There is some good evidence that using something called alpha lipoic acid, which is a vitamin, 600 milligrams along with your progesterone, alpha lipoic acid, and 600 milligrams along with your progesterone can help more expediently resolve a subchorionic hematoma. So that's what I do in my practice here, 100%. So does it cause a subchorionic hematoma? I'd say no, it's not that it causes it, but certainly if you are prone, if you're being anticoagulated with Lovenox, then it certainly can contribute to it. But what causes it is really probably just the forces of the uterus growing and the placenta kind of moving along with it. Let's see here. Hey, Jasmine, if you're still there. Let's see, what would, no, we answered that one. Hi, Noodles for Life. Dr. Fink, it is hard to grow a lining. Is it hard to grow a lining after 60 days of suppression? How soon to see improvement after intrauterine PRP? Well, certainly if you have been on hormonal suppression for endometriosis, you may find that it takes a little longer for you to grow a nice thick lining. Intrauterine PRP is a great thing to do. It really has a local effect of kind of putting your growth factors, your tissue factors, your healing factors right on the what we call the basalis, which is the kind of also maybe known as a basement membrane, where that endometrium grows from. You're putting that salve right on there, which may help that endometrium to grow. Really, probably what has to happen is that you probably just gotta wait for the estrogen to do its thing on those receptors, and it should grow itself. But yes, sometimes we do see things going a little bit slower after having done suppression. That's one reason that sometimes I favor doing a medicated embryo transfer cycle instead of a natural or a modified natural cycle after suppression, precisely because if we're trying to let nature do its own thing and your own hormones make that lining grow, they may just work slowly as a result of that suppression. Whereas if we're giving you the estrogen to make it grow, we're giving you levels enough that hopefully it'll grow. So it's my 2 cents worth there. Oh, hi, Angelina Foxy. We were just talking about you. I hope you heard a few minutes ago. Hey, the Tongue family. Brock, nice to see you this evening. Any tips for PIO shots, swelling, and knots? We switched oils and still have severe knotting. I will tell you that progesterone in oil is one of the more difficult things that we have to deal with, it really is. Some people talk about putting ice on the area before doing the injection and immediately afterwards putting heat on it, and that combination, and then of course kind of massaging it. But yeah, it really hurts, and it can create a little what's known as fat necrosis in the fatty tissue that overlies the gluteal muscle in the butt. And the idea of icing it first, and heating pad probably feels pretty good, but then rubbing it when it's going to be sore, it's a tough thing to do. And that really is kind of one of the advantages of doing a modified natural FET, is that you don't have to do the progesterone and oil. Your own hormones, like you make every month that you have a period, just seem to make life an awful lot easier. I have seen gosh, and I can't think of what it's called, but there's this belt that you can get, that you wear, and you buckle it in the front, and it's got a place, it marks on your hip where you should be getting the shot, and it's got a place to put a little ice pack on it before, and then a little heat pack on it afterwards. And so it's just kind of designed to try to soothe that area. But yeah, the PIO shots are they're really no fun. Daisy down in Miami, nice to see you this evening. Hi, Alicia. Let's see, do you ever get to choose? Here, this comes from Amber. Choose a doctor for delivering your baby. Just seems like you get whoever is on call that night. So, the way most obstetric practices work now is that most of them are group practices. And so they have a rotating call schedule. And indeed, it's whoever is going to be on call that night. Now, there are some docs who still try to deliver their patients, but unfortunately, the era of the solo practitioner who would, kind of do all their own deliveries has really gone by the wayside. Even when I practiced OB, I tried as much as I could to do my deliveries, but here's the problem. Insurance reimbursement for obstetric care has dropped to the point that, to ask a doctor to give up everything in their own personal schedule, really without truly being reimbursed for that time, and to accept all that liability and everything else. So many practices have evolved into a group practice model where they share those call responsibilities, and if the delivery is taking place after hours, it turns out that, yeah, you're taken care of by the person that's on call, which is a good reason to try to meet everybody that you can in the practice. Now, most of the time in these group practice scenarios, people are pretty similar. They have very, very similar practice styles. Hopefully most of them are really pretty nice, or they wouldn't be in the business of OBGYN. They should all, really be solid providers. And if they are good enough to work with the doctor that you like, then you should feel pretty comfortable that they will be good enough to deliver your baby. But I know there are personality things, and gosh, you become attached to your own doctor. Many docs will try to deliver their own patients if they can during the daytime. But when it comes to night call, oftentimes those call responsibilities are indeed shared, so that one person isn't up all night every single night, delivering babies, and missing all that time during the day when they're supposed to be seeing patients in the office. It just becomes somewhat untenable. But there are still other places that work on the model of what are called laborists. And a laborist is an OBGYN doctor who is typically employed by a group that the hospital itself employs. And those laborists are people who are there in the hospital at all times, and so they can step in immediately in case of emergency. But it may be that your doctor works out a deal with them that they may just be able to deliver you That's something else that has kind of evolved in the practice of modern day obstetrics. And so, Amber, you raise a good question. I think it's important. That's a good question to ask of your OBGYN. How does delivery work? Is it a laborist in the hospital, or is it someone from this practice? Is it someone who I have the potential to meet if I'm going to rotate through in my OB visits? And, I think that's probably a pretty good idea. It does make sense if you can to try to meet everybody in the practice. Hi, Shadia. Nice to see you this evening. Let's see. It looks like Shada says, would you do priming? What would you do priming? What would you do priming with, norethindrone or estrogen? What works better and for how long? And how long after would you start stim? Right after or a couple of days after? Okay, fair enough. So I think there's the best evidence for using some hormonal priming before stimulation is using estrogen, because estrogen is really the language that the ovaries speak. And so when we use the estrogen, it increases the blood flow, it increases the vascularity going into the ovaries. Progesterone, not as much. Progesterone can definitely prevent you from ovulating, which is a good thing, but estrogen would typically be my choice. Usually there is a little bit of a washout period after stopping the estrogen before starting your stimulation. If you have used estrogen with a progesterone, such as a birth control pill, typically that washout period is about 5 days before starting. Much more than that, you're not doing as well. You don't really want to start too much later than that. That can have an adverse effect. 3 days you can, but I typically look at 5 days, especially if I was using combination estrogen and progesterone, like you might see with a birth control pill. Hi to Florida Mama Lynn's, and looks like Katie B doing things. What are your thoughts on on pre-pregnancy transabdominal cerclage after 2 cone biopsies that did not leave much of a cervix at all? Well, so an abdominal cerclage. So a cerclage is a stitch that goes into the cervix and helps to hold the cervix closed. And if you have had 2 cone biopsies where they removed a big part of the cervix, a cerclage may be in your best interest, especially if you have had a history of pregnancy loss after that, or what we call an incompetent cervix. Now, what I'll tell you is that an elective cerclage is always going to be better than an emergency cerclage. But doing an abdominal cerclage, most of the time the cerclage is a stitch that's placed in the cervix. The abdominal cerclage is placed much higher, and that is not something that every doctor knows how to do. Typically an MFM, maternal fetal medicine doctor, does abdominal cerclages. Most general gynecologists do not. So finding a doctor with the expertise to place an abdominal cerclage would be trick number 1. But I would say, yep, if there's no cervix left, I think it is a very reasonable thing to do, to say, let me prophylactically put a stitch there to help hold that pregnancy in, because it's way better to do that before you have a problem. Because if you wait until you have a problem, and that's what I mean by an emergency cerclage, if you wait until you have a problem, the outcomes are not nearly as good. But that's a great question. If one has missed some days of prenatal or hasn't taken any prior to IVF, does it mean the retrieved eggs may result in birth defect babies? Can it be saved by taking prenatals during the first trimester? Well, I think really the issue is just kind of filling your stock before you get pregnant is really the bigger issue, I think. So Yes, some of the micronutrients and certainly the folic acid can have some beneficial effect on egg quality. But the bigger thing, as far as the folic acid goes, is the spina bifida prevention, and that's the spinal type birth defect. And as long as that's in your body, as long as you kind of fill up your folic acid stores, the more important point is once you are getting pregnant. So somebody can do an egg retrieval and make embryos, and then maybe they wait for 3 years before they decide they want to get pregnant. Well, it doesn't mean you have to be on prenatal vitamins for all 3 years leading up to it, but I would say at the minimum 3 months before doing the embryo transfer, because you want to be on that folic acid for 3 months prior to conceiving, and that is getting the pregnancy inside, not so much from an egg quality standpoint. How many milligrams of omega-3? I believe it's 900 milligrams. It's 900 or 950. It's a lot more than you would think. Odorless, burpless. That is for sure what you want. Well, folks, let's see. We got a few more minutes here tonight. I hope you're enjoying the program as much as I'm enjoying being here with you. And let's see what else. I think we have some more questions over here on my Instagram side, and that's Randy Fink MD. Please follow me. I try to get some content out there. I need to do a better job on that instead of just relying on Tuesday nights, and that's my part of my New Year's resolution. Let's see. Hi, Ruby. Let's see. Hi, Zenaida down in Miami. Thank you for being here. Natalie is here. Jay Palmyro. Howdy. After being done with breastfeeding, asks Rosa, for the next transfer, do you recommend letting periods return or going for another 2 months of suppression before transfer, given that I have advanced endometriosis? Well, so once you're done breastfeeding, and this is actually something that people do ask us about a lot, they'll come back in, they'll say, well, I'm breastfeeding and I still want to continue breastfeeding, but I'm ready to get pregnant again. And I would say, we really don't like to do that for a couple of reasons. One is that, well, while you're breastfeeding, you may not be ovulating normally, and the medication that we will give you in order to make you ovulate will both affect the milk supply and can go in and affect the baby. So, we're just not going to do that. But we don't recommend pregnancy during breastfeeding because it creates nutritional challenges, both for the baby that you're feeding on the outside, who at that point probably, hopefully anyway, is already on solids. And secondly, and for the baby on the inside, it really does create challenges. The miscarriage risk is increased, the pregnancy rate goes down. So we really want you to be done with breastfeeding. The question is, well, do I need to be having periods or should I just go into suppression? Rosa, in your situation, because you have that large endometrioma, we know that you have endometriosis, right? It's not a mystery. And, a simple ultrasound will be able to show us that, yep, that endometriosis is still there. So 100%, I would say, I think suppressing that endometriosis before doing another embryo transfer is the right choice in your case. Is there a reason that you need to have a period before you start to do that? And the answer is no, not necessarily. Not necessarily. You can go on suppression without having that period. Hi, Indepino Journey, and Zenny is over here now. Zenny, you're like one side to the other. You're making me dizzy. I don't know which way to go. Don't know which way to go. Let's see what else we have. A couple of other. There was another question here I saw about. The question was that sperm thing you talked about earlier. Does it hurt? And I said, well, in general, no, not while doing it. There are some places that will even do that procedure under anesthesia, but I have seen it so many times just under local that sedation for it is really not necessary. You are a little sore afterwards, but it is not nearly as barbaric as it sounds. So there you have it. This whole infertility business is not the book of your life. It is really just a chapter. And what are we here to do? We are here to rewrite that chapter together. So, my hope for you is that every step forward is one with kindness. We talked about the kindness thing before. Not enough kindness in the universe. So please reach out, do random acts of kindness for strangers, smile at someone who's not expecting it. Wave at a child, make a child laugh, do something nice for someone, because that's how we make the world a better place. And it really, truly is one mind at a time. Every step forward with love and every step forward with hope, knowing that tomorrow is a new day and that new day is full of all new adventures. So until next week, thank you so much for being here tonight. I'm Dr. Randy Fink in Pensacola. To all my friends on the Gulf Coast, in these United States, in Missouri and in Oklahoma, everybody who got frozen this past weekend, again, thanks so much for being here. Good night.